Welcome to our video history project for the American College and American Congress of Obstetricians and Gynecologists. Today we're very fortunate to be able to interview Dr. James Martin. Dr. Martin, past president of the college, was one who helped to shepherd the major changes between the college and the Congress and the merger and organization and change. And we'll get into a little of that in a minute. But first, Jim, thank you very much for coming, and thank you for willing to be interviewed.
Thank you for the invitation.
Let's just begin a little bit about your personal history. I know a little bit about your North Carolina ancestry, but tell us, where were you born and where were you raised?
I was born actually not too far from here at Bethesda Naval Hospital. My father was a lawyer who went off to World War II and returned and went into the JAG Corps of the Navy, later became JAG. And we lived in Arlington and then in Pearl Harbor, back to Norfolk, and then Jacksonville, Florida. And I finished up in high school in Newport, Rhode Island at Middletown High School, and then went off to college from there.
Where'd you go to college?
Went to Wake Forest University in Winston-Salem, North Carolina. Met my wife there too.
Let me ask you a question. When did you decide that you wanted to become a doctor?
Oh, I think I wanted to become a physician from the time I was a child. My mother was a very bright woman who wanted to be a physician herself. And my grandfather's an OBGYN general practitioner in Eastern North Carolina. And I think she began whispering to me when I was a child that, oh, someday maybe you'll be a doctor, like your granddaddy. So I think I grew up with that seed planted in my mind.
And your medical school?
Went to North Carolina. That's all I could afford to do because my wife and I had married just 5 days before medical school. She wanted to get a master's degree in social work, and UNC in Chapel Hill was the best place for us. It was close to family. It accepted me as one of its 10% of out-of-state students because I was still considered to be from Virginia. And I was impressed with Chapel Hill, and really Bowman Gray would have been a bit of a financial leap to go. And Gloria could not, my wife could not have gone to get a degree there at Wake Forest in social work. So Chapel Hill it was. Very good place to go to school.
When did you decide you wanted to be an obstetrician gynecologist?
I thought that was the last thing I wanted to be when I went to medical school. I was a classmate of David Grimes. We were good friends, and we really enjoyed, I think, the OBGYN rotation better than anything. It was my second rotation. I went to Charlotte for part of it, and Dr. Pinckney Rankin was the OBGYN in charge of the rotation at Charlotte Memorial Hospital. I think it was during that 6-week rotation that I decided that I really belonged in OBGYN. Didn't like the nighttime aspects of it, the lack of scheduling, but I loved taking care of women as patients, and I really liked the subject material. You were sort of an internist for women without having, and a surgeon, without having to limit yourself a great deal in other ways.
When you graduated, where did you go? I assume at that time you had to take an internship.
You did. I was fortunate in that my father told me that the Vietnam War was going to end. He was still in the Navy. And so I didn't commit to anything in the military at that point. I decided to go and accept a residency there at Chapel Hill. Dr. Chuck Hendricks was the chair. And he recruited me and 4 others. We occupied the 5 positions, and David Grimes actually was a 6th resident, and David went off to another CDC and then returned later on when I came back. We sort of shared a position back and forth. So I did most of my all my postgraduate work there for residency training, although I did take a year off to go to, all my elective time, to go to Stockholm. Dr. Hendricks was tied in with WHO, and so he arranged to let me go to Stockholm to work with Dr. Mark Bigdeman and to learn how to do clinical research. That was very formative for me in deciding to go into academic medicine.
And when you came back? from Stockholm?
Well, when I came back, it was mid-residency. I mean, it was right in the middle. I finished my residency and sat down with Dr. Hendricks, and we looked at a map of the country and talked about every single site there was for training. And it was his recommendation that I consider Texas Southwestern. Norman Gant, Gary Cunningham, and that group, Jack Pritchard. And so I really never considered any other place but that one site. Went and interviewed, and they offered me a position to come, and we decided to go there.
And how long was that part of your fellowship?
The fellowship at that time was just 2 years. It didn't change to a 3-year fellowship until the mid-90s. I'm not sure the exact year, but we went to Dallas, stayed there for the 2 years, and completed the MFM fellowship.
And what made you move to Mississippi?
Well, I didn't initially. I interviewed there, but I was also interviewed at the University of Michigan. And I thought that the University of Michigan had a little more academic flavor to it that might be attractive. I liked George Morley a lot, past president of college. I liked J. Robert Wilson. And I decided to go to Ann Arbor first. I probably should have gone to Mississippi, but I went to Ann Arbor first.
And how long were you there?
2 years.
And what was your role?
I was brought in really rather bizarre in a way. Dr. Alan Beer was the new chair, and I went to Michigan ostensibly to be the chief of maternal fetal medicine. This is an individual right out of a fellowship. It was a little premature. So I went there, and Dr. Bruce Work and Dr. George Nolan both decided to leave within a year. And I had also was thinking that the environment was not the best for me, for a young person to develop a career there. And I reconnected with Mississippi and went there in 1981.
And been there since?
And I've been there since.
Now, what was it about maternal fetal medicine that made you want to subspecialize or super specialize, depending on your point of view?
You know, I'm not sure exactly, except that the field really was very attractive to me. I liked emergency obstetrics. I really liked medical complications of pregnancy. I became fascinated when I was a resident at Chapel Hill with some of the difficult situations we dealt with without good answers, some of which were related to preeclampsia. I recall losing a patient that was formative, and I decided that I was going to try to become as well educated as I could in hypertensive disorders of pregnancy, and to become the best clinician I could be in that area, and to do clinical research in that area as well. I did not want to really be a bench researcher. I wanted to be a clinical researcher, and you really have to with preeclampsia.
I think you probably succeeded, because I think you're probably one of the best known OBGYNs in our country and probably in the world.
We just had one of the largest groupings of difficult patients and complicated situations that we had to work through. So it was very, very fortunate that I went there, as it turns out.
Who was your chair at that time?
I went to work with Dr. Wynn Weiser. I think Wynn was probably the best chair I ever worked with in the course of my career. He was an exceptionally capable individual who was a master administrator, an expert surgeon, and just had very good balance to him.
And actually an overall very nice guy.
Oh yes, yes. He was very, although very, he was in the autocratic sort of I am in control situation type of chair that was so valued at that time. It's a little difficult to adapt that style of leadership, I would think, into a chair in this day and time, but he was just superb. One of the best things about him was that he looked after his faculty, and he basically challenged us to do what we wanted to do, and then he got out of the way after he helped facilitate us getting done what we needed to get done.
Let me take you back. When did you first get interested or involved with the college?
Ralph, I'm not sure exactly. I became involved peripherally as a resident, but it wasn't until I went to Michigan that I became active in ways like that. And then during the 1980s, I became much more involved with ACOG because of teaching. District 7 was right there. Mississippi was active, one of the 34 university centers within that District 7 area. And I was encouraged to do some of the postgraduate teaching, and it took off from there.
What was your first job or position?
Mainly postgraduate courses. I will always be grateful to Frank Miller, because Frank was hired to go to the University of Kentucky, I guess it was, or Arkansas. Let's see, did he go? No, he went to Arkansas.
Arkansas.
Went to Arkansas, and he left District, that was District 7, but no, he was at Arkansas, but he was hired to go to Kentucky.
Right.
And because of leaving District 7, they asked me in the early 1990s to be the program chair for District 7, because they, Dr. Weiser, I think, was their first consideration, and Wynn declined and asked and suggested, I guess, that they approach me. So Frank Miller's leaving District 7 made an open slot, an opportunity for me. I've been grateful to him ever since. So we chat about that whenever we see each other.
And after being program chairman, what was your next office or position?
Well, in District 7, at that time, one began as program chair and then became the treasurer and the secretary, the vice chair and then chair. So I began that sequence of events. I almost bankrupted District 7 in my first job because they told me to do the best possible meeting I could, and we had Venice and Vienna on the schedule, and so I thought I was doing the right thing, and in fact the district leadership went with me over to those places to site visit them, and we recruited a wonderful program. We had a great time. Unfortunately, we had only, I believe, close to 120 people that signed up for the district meeting that year in Venice and Vienna, and I think we went $100,000 in a deficit. So I spent the next part of my career rebuilding that as a District 7 officer. But they joked at me for quite a while of having done such an expensive meeting.
Now you became president of the college.
Yes.
Tell me a little bit about why you wanted to be president of the college.
I think I have always felt a desire to make a difference in terms of any organization that I've been a part of. I guess I like to be in charge. I like to be of benefit, of value to any group that I work with. I became active with the Society for Maternal Fetal Medicine about the time I was working with ACOG in the early phases of my career, and I became president of that organization in 2001. And I spent, I guess, 9 years there during the time that I was beginning to be more active with District 7. So I really had wanted to transition and to become a president of the college years before I actually did it. But we had manpower issues at Mississippi that argued for me being, for continuing there as a clinician full-time much longer than I had planned. And so I ran for secretary of the college and was fortunately able to support that position for 6 years before I ran for president. And that allowed me the time to really watch and learn from a number of outstanding presidents as we went along. Of course, you know we cannot repeat as secretary more than one term nowadays, but it was really fortuitous for me because I was able to watch such outstanding people as Chuck Hammond and others that each brought a different style to leadership, and I could pick out the things that worked and the things that didn't work as well, so that when I began, had the opportunity and was fortunate enough to become president of the college, I had acquired, I think, a better skill set and a better way of operating meetings and listening and choosing what sort of things would be best to do.
During your presidential initiative, we get probably the most outstanding work the college has ever done. And hypertension in pregnancy. Obviously, from your background, that's what you wanted to accomplish.
Well, thank you. We had not, as a college, really revisited the guidelines since 2002, I think. And in fact, as my recollection was that even in 1996, the time before that, we still had not really brought them up to where I thought they should be. In 2005, we published some work out of our institution in Mississippi, which made a paradigm change, I think, in how we looked at the approach to treating the high blood pressure in these women, to changing from the diastolic focus to the systolic focus. And by the time I became president in 2010, there really didn't seem to be much action in terms of assimilating that into practice. So a primary goal of mine was to look at the whole field, really do a thorough review of it, and try to move things into mainline practice that were modern and really best for women's health.
I think that's not only the quote-unquote Bible of modern-day management of hypertension in pregnancy, but I know from practical experience it's also the worldwide reference being used now.
Well, ACOG has a great deal of respect around the world, I've discovered. We are the biggest, and I think probably one of the best run OBGYN professional bodies in the world. And our guidelines are followed by a lot of individuals. Those of us and the Royal College are probably two prime examples. So yes, it really was helpful to do that. But you know, the guidelines were, in one way, limited ourselves because we really sought only level 1 evidence, and that's what the guidelines are built on. And so much of preeclampsia is much more than level 1 evidence. There's so many little pieces off to the side and areas that demand a lot more than large randomized trials. You just can't study it like that. So I'm teaching this course tomorrow afternoon that I'm really looking forward to with John Barton and Donna Johnson out of South Carolina, in which we're going to teach beyond the guidelines. Put more flesh on the bones of those guidelines, if you will. So that's going to be fun.
Let me take you back now to your presidency and your presidency lecture. That was a time of great change in the college in terms of we no longer were going to become the American College, we were now going to become the American Congress. Tell us a little bit about why we were going to do that as the college.
I think it was a natural part of growing up and maturing more, if you will, that our role in women's health care and advocacy, particularly advocacy, was expanding, and the need to be a very active advocate for women's health at the Congress level, state, national, was growing. And as a 501c3 organization, as a college, we were restricted somewhat in the amount of advocacy work we could do. We had a superb team of people. Lucia DeVeneer is just a phenomenal person and talent in that area. So it became important to add this other facet to us, to create the Congress. At least my understanding of it was to be able to allow us to really broaden our impact in women's health care, to be more of an advocate as well as an educator. I think many people think of ACOG as the premier OBGYN organization for education of our practitioners, but we also have a major responsibility and role in terms of educating and advocating at the congressional level and the state level for legislation that really benefits women.
Obviously, I would have to agree with you since I was president during that period of time. But tell me what resistance you felt that we had in trying to make this double-edged sword that we were creating.
Oh, I guess some resistance. There's always resistance to change to some extent. Just the name. I mean, it's been confusing, I think, for OBGYNs to identify, well, why are you calling us the Congress? We like the college. And educating our membership was a big part of that. But I think also the reality of our needs to advocate in a political arena is not something, it's not a suit of clothes that most OBGYNs are comfortable wearing. I think there may be a tendency to be more averse to that kind of activity for OBGYNs. So getting them to realize the importance of it and expanding that role and moving us in that direction, I think, was important to do.
Let me switch gears just a little bit now. You're at a university, and a young medical student comes up to you and says they're considering the specialty of OBGYN, and they'd like to know, what do you think they should do? How would you counsel them?
Well, it used to be a very common occurrence. I retired from the university in December of 2014 and stopped clinical practice, at least at that time. And this happened all the time. And I would sit down with each of those individuals and try to learn why they wanted to do OBGYN, possibly. Because I have had at least one resident that came to me a month or 2 months into residency to say that they made the wrong career choice. So I wanted to be sure that, why do you want to do this in the first place? But the reasons I would tell them that they might want to consider it is that it's the best specialty in all of medicine to me. We have such we have such variety and potential with women of virtually all ages after pediatrics. One can choose to go into surgical aspects of it, the medical aspects of it, focus only on pregnancy, focus only on later stages of life, menopausal. It's just such a great specialty. And I waited until the end of my residency, I think, to really decide that I wanted to do maternal fetal medicine. And what I would tell these students would be, you need to choose something that you will be happy and excited to do every day of your life. You need to, when you wake up, if you say, I can hardly wait to start, then that's probably got your name on it.
Let me take that one step further. What would you say to the student that says, well, but aren't there some negative aspects, some things I should need to consider?
There are negative aspects in everything. I mean, yes, certainly. I was walking behind a couple medical students not too long ago, and they were talking about the most desirable specialties to go into that would be the least demanding on their time and least night call and so forth. OBGYN can be very demanding. It's we deal at some very sensitive times in a woman's life. Birth is just an amazing time. There are significant risk and things that we just can't anticipate that can occur during that. So you have to have some resistance to stress. You have to be able to be awake and alert in the middle of the night. That's not always easy, and I found that you begin to lose that ability about age 55. At least I began to. But there's just so much to benefit in the relationships one builds with patients in this process that I really thoroughly enjoyed. Plus colleagues in the area. It's exciting to do this kind of work.
What would you say as you were counseling a young or OBGYN or even a student thinking about going to OBGYN, what to look forward to in this specialty? What's going to happen to this specialty?
The specialty is going to change, undoubtedly. I think it still is going to offer opportunities to all of us in this area to transition with it. I think this change to value from fee-for-service is a challenge. We'll still have the same patients. It's just that how we resolve to get it paid for and to maintain our educational edge is going to change a bit. The biggest challenge that I've seen in our unit was the shortening of the work hours that we had to learn. And it was a good change in many ways because we really worked too long, too many hours, and we were too tired many times to do some things. But on the other hand, it didn't make us as capable at the outset of going into practice. So that time has been shifted into early practice to pick up some of that information. There has been talk for a long time about perhaps changing OBGYN into more of a tract system. Personally, I really like the idea of us first getting a strong foundation in general obstetrics and gynecology before we subspecialize or decide what facet we're going to do. And so have always been a little resistant to the idea of early on in your career, in your training, like in the end of the first or second year, saying, I think I just want to do office practice and therefore I don't want to learn anything about surgery. I think that is that could be short-sighted, because if you change your mind, and we all change our minds, you might be sorry you didn't get that training at the beginning.
What do you see about the future of the American College, American Congress?
I think the American College and American Congress are in wonderful shape. We have always had phenomenal leadership. I was just at a meeting at noon today with some of the former leadership district chairs, and it just reminds me of how we have such great people. I don't see that changing. We are going to change quite a bit in terms of having many more women in the specialty. That makes for different challenges and different opportunities, and I think that'll change a lot the flavor of things. I think we have to keep it attractive to spouses of those women that are in the specialty to come to meetings, although I think meetings themselves are going to be changing and shortening and changing our educational models quite a bit. We are challenged as a college and a Congress to stay relevant, not only to different practice needs, to develop educational changes to these guidelines we use, to show relevance to our membership of what value we can bring to them, to advocate for them at a level of Congress and so forth, so that we don't have people that are outside medicine trying to practice medicine for us or instead of us in our offices. There's always that challenge. The litigation issue is always something that's been there, and it continues to be. It causes us, in a positive way, if one can look at it that way, to be very zealous about keeping on our the top of our game in terms of how we practice, to really stay educated. I'm very grateful to people like Larry Gilstrap and the American Board that have made it their business to make it easier for clinicians in our specialty to learn and to be credited with that through credits and education, so that we can stay board certified. That's all been good. So I guess I feel like I've lived through one of the best eras of OBGYN in our country. But I'm optimistic that with the leadership that's coming on board, that it's going to continue to be very good.
Jim, I want to thank you very much for coming. You are actually one of those leaders, and we all know that. So we really appreciate your willingness to share your ideas with us.
Well, thank you very much.
Put it on public record.
Okay.
Thank you very much.
Yes, sir. Thank you.